Roughly 1 out of every 3 patients in the intensive care unit, on average, are unable to communicate. Because of this, the role of an ICU nurse stretches far beyond providing medical care alone, but also acting as an advocate or a voice for the voiceless, to ensure that these patients' needs, rights, and wishes are heard, recognized, and respected. In doing so, we as nurses embody the very essence of healthcare: compassion, advocacy, and an unwavering commitment to patient welfare. Hey there, my name is John Hawes, RN, CCRN alumnus, and founder of nursing.com. And in today's video, we're going to be talking about advocating for patients, but more specifically, those patients who can't advocate for themselves. And then I'm going to share some stories from my experience working in the ICU in one of the busiest hospitals in Dallas, Texas. Welcome to the heart of critical care, the ICU. In this unit, the battle between life and death unfolds rapidly every day. And at the forefront of this battle are us, the heroic nurses, that navigate these circumstances continually. The ICU provides critical medical care to people that have life-threatening injuries and illnesses, and as a result, are in an increased state of vulnerability during hospitalization. This unit typically sees a staff-to-patient ratio of 1:2, has specialized staff with access to medical procedures and medical equipment that isn't normally available throughout the rest of the facility. Patients with rapidly deteriorating conditions will often be referred here directly from the emergency department, or they could be referred here after a surgical procedure. In the United States, roughly 10% of hospital beds are considered critical care beds. Some of the most common conditions that are seen in ICU are sepsis or septic shock, trauma from road accidents or burns, acute heart failure, acute kidney injury, pneumonia, acute pancreatitis, ARDS, poisoning, gastric bleeding, or surgical complications from surgery. As an ICU nurse, you really are the patient's first line of defense and play a key role in advocacy, as you tend to spend more time with the patient than the provider and the family combined, and are able to pick up on those nuances that are oftentimes missed. You are in a unique position to advocate for the patient's comfort based on your observations. Oftentimes, family members may fall divided on the patient's care plan. So it is the duty of the nurse to advocate for the patient, not only based on their previous wishes, but also based on your ongoing professional assessment. During my time working as an ICU nurse, I took care of a lot of patients through some of the darkest and hardest times of their lives. But there's a couple situations that have always stuck with me where I had to act as an advocate for patients who were unable to communicate themselves. I would like to share some of those stories with you to kind of put all of this into perspective and hopefully help you on your journey as a nurse. Now, the first story I want to share is of a woman who had had a chest tube placed during surgery. And when I arrived for the shift that evening, it was very clear that she was in grimacing pain, complaining of the pain right near the insertion site of the chest tube. Now, the physician who had placed this chest tube was actually a neurosurgeon, very good neurosurgeon, but he had limited experience placing chest tubes. And a patient's not supposed to have that kind of pain right where their chest tube is, or anywhere near really that kind of pain. So I knew something was wrong. Now, although it was nighttime and this wasn't a life-threatening complication, during the day shift, the nurse was unable to get the nurses or the physician or anyone to take another chest x-ray to verify continual correct placement of that chest tube and why she was feeling so much pain right there. Now, as the shift progressed, so did her pain. Her pain got to the point where she was unable to open her eyes, move, or even talk. Just really sit there in bed and just be grimacing, just, it hurts, kind of like that. So I called and I woke up the on-call physician in the middle of the night to request an additional x-ray to verify correct placement of that chest tube, despite the fact that if this chest tube was placed poorly, it would mean that that great neurosurgeon had done something wrong. Now, in the end, the chest tube, in fact, was placed poorly, was actually too high, and was nearly puncturing her lungs, so every time she would breathe, it was rubbing against that chest tube inside her chest. Now, the options were weighed, and the chest tube was removed, and the moment that chest tube was removed, the pain went away, and she was actually able to rest. Now, in the morning time as I was preparing to leave, and I'll always remember this because it really stuck out to me, I was really doing something very simple of just getting that chest x-ray. She said to me, she said, "John, you were like an angel last night. Thank you for caring." Now, the next story is of a young man who came into the ICU after a car accident. And he was in relatively good health, except for some minor injuries from the wreck. But when I went in to complete my beginning of shift assessment, he complained of some chest pain and maybe a little bit of pressure on his chest. And I was a relatively new nurse, but I listened to his heart, and I went back to all that I had learned in nursing school and in studying as I started my job in the ICU, and I began putting the pieces together. I didn't want to look, though, overly zealous to find anything or anything like that, but I began to put the pieces together that maybe this was something that we needed to look at a little bit more. And again, even though it seemed really minor and he was in pretty good health, I went ahead and called the physician. I said, "Hey, he's complaining of some chest pain, which isn't completely abnormal for someone in ICU and stuff like that. But coupled with that pressure and some abnormal heart sounds, I said, he's complaining of some chest pain. Is there any chance we can get an EKG?" So an EKG was ordered. It got there pretty quick. We ran the EKG, and he was actively having a heart attack. So luckily that was caught. We were able to get interventions in place, and he recovered really, really well, and was able to leave the hospital very shortly after that. Now, this last story is a little bit more difficult to tell, but I think it really illustrates what we're talking about here, speaking up for our patients who are unable to advocate for themselves. One night working as a co-team nurse, my partner and I, we got a call over to the med-surg floor for a patient who they were having a hard time, arousing, and she was having a little bit of a hard time responding, and they weren't able to get a new IV started on her. When we arrived, there were 2 nurses in the room with her and the plastic surgeon who had earlier in the day performed a gastric bariatric surgery. Now, upon an assessment of the patient and reviewing her labs, it was determined that it was very likely or very possible that this patient was actively hemorrhaging internally in her gastric region where the surgery had been performed earlier in the day. My partner and I immediately began requesting blood products, and I started trying to get a larger bore IV so we could administer those blood products. And we spoke to the physician, and we said, "Hey, we need to get this patient to the ICU." Well, he refused, not wanting one of his post-op patients to have to be transferred into the ICU. So we requested those blood products, we requested a rapid transfuser from the ICU, and as we waited for those to arrive, I continued to try to find an IV, but with low blood volume, it was really, really hard, next to impossible to try to find a really good IV or place to start, this 20 gauge IV to administer these blood products. So when the blood arrived, we connected it and started trying to, give them to her, but they were not infusing fast enough. The rapid transfuser still hadn't arrived, and the patient was desperately low on volume, and she was now all but non-responsive. We again looked at the surgeon and said, "Hey, we need to move this patient over to the ICU. She can't get the care she needs here on the med-surg floor," and he again refused. No! So at this point, there were 4 nurses in the room, 1 physician, this patient who was non-responsive, and this blood was just not going into her fast enough. So I had gotten, a little, or a 20 gauge IV put in, but it was just barely in. And again, these blood products were not infusing fast enough. My partner and I came up with the idea. We're like, "Hey, what if we try using a pressure bag, pumping that up to try to squeeze that blood in a little bit faster?" Well, immediately when we did that, we got it pumped up to a decent pressure. The blood bag tore on a couple of the seams, and blood began coming out onto the pressure bag and down some of the lines. So my partner removed the blood bag from the pressure bag, climbed up on the bed, and started squeezing the blood to try to get it into her, kind of holding it up above his head. Meanwhile, I'm trying to get, an IV started, something deeper into a vein, but nothing, I can't find anything. Meanwhile, the surgeon's, at the foot of the bed, a little bit in the corner of the room, and he's still not wanting to move this patient to the ICU. So at this time, me and my partner were like, "Look, this patient is going to the ICU." So while my partner's up on the bed squeezing this bag, I called a surgical ICU and I'm like, "Hey, we need to get this patient over there. Please get us a bed ready." They said, "Okay, we can have a bed ready." I unlocked the bed. We look at the surgeon, we're like, "She has to move." And at this point, he relented and he said, "Okay, let's take her over to the ICU." So my partner climbed fully up on the bed, kind of right next to the patient. I unlock the bed and I start running down the hall of the hospital to try to get her over to the surgical ICU as fast as I could, while he's just trying to squeeze this blood into the patient. When we arrived over in the surgical ICU, the room was ready, the bed was ready, all the nurses were there, ready to give her the care that she needed. And at this point, I left her in the care of those competent nurses and returned to carry out my duties for the night. The next evening when I came on shift, I went down to the room that we had brought her to, and she was fully awake and alert. She had no clue who I was because she was completely out the night before, but she was awake and she had received all the care she needed to be okay, to be safe. Being a good nurse doesn't mean being subservient and simply carrying out orders. It means being the voice for the patient when they're unable to speak for themselves, and ensuring that they're getting the best care that they can so that they have the best possible outcomes they can have. In closing, the ICU is an exciting, challenging, and rewarding place to work. The compassion that's shown by ICU nurses as they strive to remain a voice for the voiceless is never lost on the patient or their family. For more on cardiac care and the cardiovascular system, which is a vital skill as an ICU nurse, be sure to visit nursing.com/heart, where you can watch videos, download a cheat sheet, and even take a quiz to see where you're at in your cardiac knowledge. All right, that's nursing.com/heart. All right, we love you guys. Go out and be your best self today. Happy nursing.